Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the deep dive. Today, we're tackling a topic that, well, it comes up all the time in clinical practice, doesn't it? Hemorrhoid management.
It really does.
Specifically within NHS general surgery. And while it might seem common, the structured way the NHS approaches it is actually quite precise and really fascinating. Our mission for you, our listener, and this is especially for you if you're a doctor or surgeon, maybe in training or already practicing, is to really distill the key bits, the diagnosis, management, follow-up strategies, all straight from those core NHS general surgery guidelines.
Yeah.
Think of this as your sort of essential quick guide to the stepped care approach for this very common condition.
And what's really interesting, I think, is seeing how NHS management balances cost effectiveness with patient outcomes.
Yeah.
Starting conservative, only moving to surgery when it's truly needed.
Right.
So this deep dive should give you that foundational knowledge, that understanding of the pathway.
Exactly. We'll be unpacking the nuances of diagnosis, the essential workup, what you really need to do, the different treatments from first line right up to the more complex surgical stuff, and, what good follow-up actually involves.
Okay, but just a critical point before we really get into it. The information we're discussing here, it's for reference, okay?
Right.
For understanding. Always make sure your clinical practice follows your local policies, institutional guidelines, and of course the latest clinical evidence.
Absolutely crucial.
This is about informing your understanding, definitely not replacing your professional judgment or those established protocols. Right. Okay, let's unpack this then.
Okay, so let's picture it. You've got a patient in front of you, clinic maybe, symptoms suggest hemorrhoids. Where do we actually begin?
Right. Well, diagnosis always kicks off with a careful history and a thorough examination. It's absolutely crucial. Not just to confirm the hemorrhoids, which is important, but maybe even more importantly, to rule out anything more serious lurking underneath, particularly colorectal cancer. That's got to be top of mind.
Right, the red flags.
Yeah.
So what are those absolute key symptoms you're listening for in the history? The things that make you think, okay, this sounds like hemorrhoids.
The classic one, the hallmark, is bright red rectal bleeding, usually seen on the toilet paper or maybe dripping into the pan after the motion, not typically mixed in with the stool. That's a key point.
Okay.
Then there's prolapse. So tissue actually protruding from the anus, often during straining, and you need to ask, does it go back on its own or do they have to, manually push it back in?
That distinction sounds important.
It's very important for grading, as we'll see. Then you might get discomfort, maybe itching, but usually not severe pain. That's another clue. Unless, of course, you've got a thrombosis, a clot.
Okay.
And naturally, you've got to clarify their bowel habit. Are they constipated? Do they strain a lot? What's their fiber intake like? All crucial bits of the puzzle.
So the history gives you clues, but the physical exam must be where you really start to confirm things and rule out differentials. What are you looking for there?
Exactly right. Inspection is vital. You're looking for external things, skin tags, maybe those obviously painful thrombosed external hemorrhoids, or clearly prolapsed internal ones. But you can't stop there.
No.
A digital rectal examination, the DRE, is non-negotiable. You need to assess anal tone, feel for any internal hemorrhoids low down, but critically, rule out any low rectal masses.
Yeah, you can't miss that.
You absolutely cannot miss that. It's foundational. It might feel awkward for the patient, but its diagnostic value is immense. And then here's the cornerstone for really pinning down the diagnosis: proctoscopy or maybe sigmoidoscopy. This lets you actually see the internal hemorrhoids.
Right, direct visualization.
Direct visualization at their classic spots, 3, 7, and 11 o'clock at the patient's in the lithotomy position. And this view lets you grade them accurately. And that grading, it directly dictates the management pathway.
Okay, that grading system. It seems straightforward on paper, but maybe walk us through those grades quickly, and perhaps any tips on making that distinction in practice.
Sure, happy to. Think of it as a spectrum, mostly about the prolapse.
These bleed, but they don't prolapse. They stay inside.
Okay, internal only.
Exactly. Grade 2. They prolapse when straining, like during a bowel movement, but then, importantly, they go back in spontaneously afterward.
Pop out, plop back in. Got it.
Grade 3. These prolapse, but they need manual reduction. The patient has to physically push them back inside. That's the key difference from grade 2. You have to ask that question.
Right. Do you have to push it back?
Precisely. And grade 3. These are permanently prolapsed. They're stuck outside and can't be reduced. They're always there.
That's very clear. And I guess a common trap might be mixing up grade 2 and 3 if you don't ask about manual reduction.
That's exactly it. Asking that specific question is crucial for accurate grading.
And this thorough assessment, it's not just about confirming hemorrhoids, is it? It's constantly weighing up the differential diagnoses, too.
Constantly. Could it be an anal fissure, a fistula, maybe rectal prolapse itself, perianal warts? And always, always at the back of your mind, particularly with bleeding, could this be colorectal cancer? You have to consider and actively rule these out.
So, okay, we suspect hemorrhoids. Maybe we've confirmed them with proctoscopy. What's the standard workup then? What investigations are typically ordered in the NHS, especially if there's, any lingering doubt or red flags?
Yeah, the workup isn't just a standard battery of tests for everyone. It's tailored. The main focus is confirming the diagnosis if needed, but more so, excluding those other causes of rectal bleeding, especially in patients over 50 or anyone really presenting with those red flag symptoms we worry about.
So routine blood tests aren't always a first step then?
Correct. Not always needed right away. But a full blood count, an FBC, might be requested if the bleeding seems frequent or heavy. You're looking for anemia, suggesting significant blood loss over time. Now, if we're looking a bit further up than the proctoscope can reach, a rigid, or more commonly, a flexible sigmoidoscopy is often done, frequently right there in the outpatient clinic at the first visit.
Oh, okay, so quite early on potentially.
Yes, it allows visualization of the rectum and the distal colon. It's a proactive step to rule out inflammation or malignancy higher up without necessarily needing a full colonoscopy straight away.
Which brings us to the colonoscopy. When is that indicated? This often feels like a critical decision point, especially regarding that 2-week wait pathway.
You've hit on a really vital point there. The NICE G12 guidelines are quite clear. A referral under the 2-week wait pathway, the 2WW for suspected cancer, is definitely indicated if rectal bleeding comes with specific red flags.
Right.
These aren't arbitrary. They're based on risk factors, things like a change in bowel habits, specifically looser stools, or more frequent motions lasting 6 weeks or more.
Or being aged 40 or over with unexplained weight loss and abdominal pain. Or being 50 or over with unexplained iron deficiency anemia.
Those combinations are key.
They are. In those situations, or if there's any real doubt about the diagnosis, colonoscopy is the gold standard to definitively rule out colorectal cancer. And crucially, it's considered mandatory before you'd undertake any actual surgery for hemorrhoids if that diagnostic doubt exists.
You absolutely can't risk operating if it might be masking something else.
Precisely. Patient safety first.
So, okay, diagnosis confirmed, red flags addressed or ruled out. How does the NHS actually approach managing the hemorrhoids themselves? You mentioned a stepped care approach.
That's exactly right. It's a very clear philosophy. You start with the least invasive options and only move up the ladder if needed, always aiming for the most effective treatment with the least burden on the patient.
Let's start at step 1 then. The first line approaches. What do they involve? These usually kick off in primary care. The GP is often the first port of call. They'll advise on conservative and medical management, and this is truly first line for all grades.
For everyone, initially.
For everyone. It's about lifestyle changes. A high-fiber diet, drinking plenty of fluids, aiming for soft stools, reducing straining, also advising against spending too long sitting on the toilet.
Makes sense.
Then there are topical things, ointments, creams, suppositories. Brands like Anasol, Sheraproct are common. They can definitely help with symptoms like itching and discomfort. But, and this is important for patients to understand, they don't cure the underlying hemorrhoid.
They manage symptoms.
Exactly, symptom relief. And honestly, for many people with grade 1st or grade 2 second hemorrhoids, these simple, practical steps are often enough.
But what if they're not? What if someone's tried the high fiber, the creams, and they're still symptomatic?
Good question. That's when we move to the next step. Outpatient non-surgical procedures. These are typically for grade 1st to 3rd hemorrhoids that haven't responded well enough to conservative measures.
And these are done in clinic?
Usually, yes, often in a nurse-led clinic or a surgical outpatient setting. The key thing is they generally don't require formal anesthesia. By far, the most common procedure here is rubber band ligation, or RBL.
Has banding.
Banding. A small elastic band is placed around the base of the internal hemorrhoid. It cuts off the blood supply, the hemorrhoid shrivels, necroses, and falls off after a few days to a week or so.
And how effective is that?
It's highly effective, particularly for grade 2 and grade 3 hemorrhoids. Sometimes multiple sessions are needed to treat all the hemorrhoidal cushions. There's a real art to placing the band correctly high enough to avoid pain, but effectively targeting the tissue.
Okay. Are there other non-surgical options we should know about, perhaps for specific cases?
Yes, there are a couple of others. Injection sclerotherapy is one. Here, a sclerostin agent, often something like phenol and oil, is injected into the submucosa around the hemorrhoid.
What does that do?
It causes fibrosis, a kind of scarring, which fixes the tissue and helps shrink the hemorrhoid. It's mainly used for bleeding grade I hemorrhoids, and it can be particularly useful for patients on anticoagulants, where banding might carry a slightly higher bleeding risk.
Right, avoids the potential bleed from the band site.
Potentially, yes. And then there's infrared coagulation, or IRC. This uses an infrared probe to deliver heat, coagulating the blood vessels supplying the hemorrhoid. It's another option, though perhaps less commonly used now than RBL in many NHS trusts.
Okay, so we've covered conservative care, outpatient procedures like banding. When do we finally reach the point of considering actual surgery for hemorrhoids? What tips the balance?
Surgery is really reserved for specific situations. We're talking about high-grade Th, those needing constant manual reduction, or grade the 4th hemorrhoids, the permanently prolapsed ones.
The most severe end of the spectrum.
Exactly. Or cases that have genuinely failed both conservative management and outpatient procedures like banding. Also, patients who have large mixed hemorrhoids, significant internal and external components might be considered.
And is it just one type of surgery?
No, and the choice of which surgical procedure is always a detailed discussion with the patient. It's shared decision-making, weighing the potential benefits against the risks and recovery time for each option.
Let's break those down then. What's often seen as the sort of traditional gold standard, especially for severe cases?
That would be hemorrhoidectomy. Usually the Milligan-Morgan technique, which is an open technique leaving the wounds open to heal, or sometimes the Ferguson technique, which is closed with sutures.
And what does that involve?
It literally involves excising, cutting out the main hemorrhoid bundles. You have to be careful to leave bridges of healthy skin and mucosa between the excised areas to prevent stenosis or narrowing of the anal canal later. It can be done using a scalpel, diathermy, or newer energy devices like the harmonic scalpel. It's indicated for those large, prolapsing grade 3 hemorrhoids. The big advantage: high effectiveness, low recurrence rates.
But the downside?
The main drawback, and it's significant, is postoperative pain. It can be quite painful, and patients need to be well prepared and counseled for this. Other risks include bleeding, urinary retention immediately post-op, and that potential for stenosis long-term.
You mentioned significant pain. Is there a surgical option that's generally considered less painful, even if it has other trade-offs?
Yes, there is. That's stapled hemorrhoidopexy, often called PPH procedure for prolapse and hemorrhoids.
How does that work? It sounds quite different.
It is. It uses a specially designed circular stapling device. This is inserted into the anal canal, and it excises a ring of the rectal mucosa above the hemorrhoids. As it staples that ring closed, it pulls the prolapsed hemorrhoidal cushions back up into their normal position and also partially interrupts their blood supply.
Okay, so it lifts rather than cuts out the main hemorrhoids.
Essentially, yes. It's indicated for circumferential prolapsing grade 2 or 3 hemorrhoids where the prolapse goes all the way around. The big plus points are definitely less postoperative pain compared to traditional hemorrhoidectomy, and often a faster recovery.
But the trade-offs?
The main trade-off is a potentially higher recurrence rate over the long term compared to excision. And while generally safe, there are some rare but serious potential complications that patients need to be aware of, like persistent pain, urgency, rectovaginal fistula in women, or even, very rarely, life-threatening pelvic sepsis.
Right. Important to counsel thoroughly. What about the artery ligation technique, HALO?
Correct. Hemorrhoidal artery ligation, or HALO, sometimes combined with rare rectoanal repair. This uses a special proctoscope with a small Doppler ultrasound probe.
Doppler. To find the arteries.
Exactly. The Doppler identifies the specific arteries supplying the hemorrhoids, usually about 6 of them. The surgeon then places a stitch around each artery to ligate it, cutting off the blood flow. If there's still significant prolapse, the RAR part, further stitches can be used to lift and fix the prolapsing tissue.
And who is this suitable for?
It's generally indicated for symptomatic grade 2 or 3 hemorrhoids. The main advantages are usually minimal pain and low major complication rates.
Sounds good. Any downsides?
Well, it does require the specialized Doppler equipment, and again, like PPH, the recurrence rate might be somewhat higher than with a traditional hemorrhoidectomy.
Okay. And one last specific situation, the acutely painful thrombosed external hemorrhoid. Is there a quick fix?
There can be. For a patient presenting with a really painful, acutely thrombosed external hemorrhoid, that sort of tense blue lump at the anal verge, thrombectomy can offer great relief.
What does that involve?
Under local anesthetic, right there in the clinic or A&E sometimes, you make a small incision over the clot and simply evacuate it, squeeze it out.
Immediate relief.
Often, yes, immediate and quite dramatic relief from the pressure pain. It works best if done within the first 72 hours or so before the clot starts to organize too much. After that, conservative measures might be just as effective as the pain starts to settle naturally anyway.
Right, a window of opportunity there. So the procedure is done, whether it was banding or major surgery. That's not the end of the story, is it? What does good follow-up look like in the NHS?
Absolutely not the end. Follow-up is tailored, just like the treatment. It depends on what was actually done.
Okay, let's start with the simpler things, those outpatient procedures like banding or sclerotherapy. What's the follow-up plan?
After outpatient procedures, the key is clear patient advice. They need to know about managing mild discomfort. Simple analgesia is usually fine. Critically, they need to keep up with the high-fiber diet and fluids to prevent constipation.
Maintain those good habits.
Essential. And they need to know what to look out for, specifically signs of secondary hemorrhage. It's rare, but it can happen maybe 7 to 10 days later when the scab or the banded tissue comes away.
Okay, do they get routine appointments?
Not usually routine scheduled follow-up. It's often an open appointment system. They're told, if you have problems or if symptoms persist, get back in touch. And if more banding sessions are needed, those are simply booked as required.
Right, patient-initiated follow-up if needed. What about for those who have had surgery? Hemorrhoidectomy or PPH or halo?
That's different. Immediately post-op, the focus is on pain management. They'll need regular analgesia, potentially including opioids for a short time, alongside stool softeners like lactulose to make bowel movements easier and less painful. Sitz baths, warm, shallow baths can also be very soothing and help with hygiene and healing.
And then longer term?
They'll almost always have a routine outpatient clinic appointment scheduled, usually around 4 to 6 weeks after the surgery.
What happens at that appointment?
The surgeon checks how the wounds are healing, assesses how all the symptoms like bleeding and prolapse have resolved, and looks for any early complications, maybe residual skin tags that are bothersome, or any hint of stenosis.
And once they're discharged from that follow-up?
The long-term advice really circles back to the beginning. Maintain that high-fiber diet and good fluid intake. It's the best way to prevent recurrence. And they're always instructed to contact their GP or the surgical unit if any new problems develop or if symptoms come back down the line.
So, bringing this all together then, we've walked through diagnosis, workup, the whole stepped care pathway from conservative to surgical. What does this all mean for you, the clinician listening to this? What's the big picture takeaway?
I think what's really fascinating, and maybe the key takeaway, is how hemorrhoid management in the NHS exemplifies that stepped care approach so well. It's a clear progression.
Yeah.
It starts with simple conservative measures, often in primary care, then moves to efficient, often nurse-led outpatient interventions for the majority, and only escalates to day case or sometimes inpatient surgery for the most severe, complex, or refractory cases.
It's really a pathway that seems built on, well, first, thorough assessment, doesn't it?
Absolutely.
And that constant vigilance about excluding malignancy. Plus, that commitment to shared decision-making we talked about, especially when considering surgery.
Exactly. It aims to ensure treatment isn't just effective from a clinical standpoint, but also efficient and really tailored to that individual patient's needs, their grade of hemorrhoids, their symptoms, and their preferences.
It really feels like a well-thought-out system.
It does. And perhaps this raises a final thought, a question for you, our listener. Thinking about this structured, evidence-based pathway, understanding the why behind each step, not just the what, how might that refine your own approach? How could it sharpen your patient counseling, maybe make your diagnostic process even more robust, or help you fine-tune treatment planning for hemorrhoids in your day-to-day practice? Are there small tweaks you could make based on this understanding?
That's a great point to reflect on. Well, that brings us to the end of this deep dive into NHS hemorrhoid management. We hope it's given you a concise but also comprehensive overview.
Yes, hopefully useful. And just one final reminder, this deep dive is for reference, for learning. Always, always integrate this knowledge with your specific local policies and guidelines in your actual clinical practice. Thanks for joining us.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.